Hello, and welcome to the presentation COVID-19, an update on transmission, control methods, and risk communication. My name is Alex LeBeau. I am the owner of Exposure and Assessment Consulting in Orlando, Florida, where we offer toxicology, industrial hygiene, risk assessment, and public health consulting services. I have my doctorate in toxicology and risk assessment. I have a Master of Public Health degree, and I am a certified industrial hygienist, a board certification offered by the American Board of Industrial Hygiene. During my career, I have performed toxicological evaluations of chemicals and biological agents. I have performed indoor environmental quality assessments of facilities, including healthcare and industrial facilities. I have consulted on occupational and environmental exposure claims, and I have authored safety assessments for consumer products, including antimicrobial pesticides and generally recognized as safe food ingredients following FDA scientific procedures. This presentation is offered in conjunction with the American Board of Industrial Hygiene. AIHA is an association for scientists and professionals committed to preserving and ensuring occupational and environmental health and safety in the workplace and the community. I am not only a member of AIHA, I am also the secretary of the AIHA Indoor Environmental Quality Committee. Some objectives for today's presentation include understanding COVID-19 disease transmission pathways and the potential for aerosol transmission of the virus, the SARS-CoV-2 virus that causes COVID-19. Look at the application of the hierarchy of controls to COVID-19 for exposure mitigation and understanding effective risk communication at facilities for effective risk mitigation for employees at those facilities. The figure on this slide is the hierarchy of controls. This is what industrial hygienists use to typically control workplace hazards. It starts on the hierarchy in the blue area, which is the most effective control mechanism, down to the least likely, which is the red, which is personal protective equipment. So if we think about this in terms of COVID-19, we look at the top, the elimination. Well, people have COVID-19 and they spread SARS-CoV-2, the virus causing COVID-19. So we can't, if we want people to be at work, we can't eliminate them. So which is the next potential control in this hierarchy? Well, it's substitution. Well, how do we substitute humans? Well, we include automation. Some of your facilities may already be partially or almost fully automated, depending on the operations that go on there. However, there are other facilities that are labor intensive that you cannot automate at those facilities. Some facilities may have offices and customer service centers associated with them or are vertically integrated into their operations. Those have to have people in them to get things done, to do administrative work, to do managerial work, to do either customer service work for clients or end users. So automation may not be possible there. Which is the next control that we can look at is engineering controls. That's the use of mechanical means within a building or facility for controlling exposure. And the example that's provided here is ventilation, and we will discuss that in detail today. The next is administrative controls. Some examples of this are workplace cleaning, our use of managing individuals at the workplace so they can change the way they interact with themselves and their environment. And the last here is the use of PPE, personal protective equipment. Example supplied here is a respirator, but usually, typically PPE is the last line of defense when you're looking at mitigating an exposure. So you want to start at the top, find out what you can do towards the top to mitigate those exposures, and work your way down once those other controls may not be as effective as you need them to be. And we'll kind of discuss those today as we go through this presentation. So I want to do somewhat of a review today on COVID-19 disease transmission. How is the disease transmitted? Well, that's a good question. The first thing we can look at is how the CDC says it is transmitted. According to them, it's mainly spread person to person. They are qualifying person to person as close contact between two people, approximately 6 feet, which is why they are recommending social distancing. They are saying that it is spread by respiratory droplets that are generated by an infected individual when they cough, sneeze, or talk. These respiratory droplets supposedly will land in the mouth or nose of a non-infected nearby individual, or these droplets can be inhaled into the lungs. They say this is the most likely source of transmission. I'll just say also potentially the main route of transmission. There's also another route that we could look at is surface transmission. It may be possible to get the virus by touching a surface that has the virus on it that contains a excretion from a lung respiratory droplet or a mucosal secretion, and the virus is surviving in that material on a surface, on a fomite, a hard surface. CDC says that they do not think it to be the main way the virus is spread. But one thing I'm going to point out here, and it has to do with the updated science on what we're finding out as time goes on, is the CDC says we're still learning more about how the virus spreads. Now, this is very important, because the more we learn, the more effective we can be at mitigating exposures and reducing risk from the virus itself. Now, as I said in the previous slide, CDC believes that the main route of transmission is from respiratory droplets or person-to-person, close contact, or from touching surfaces with contaminated materials on them, like a respiratory droplet or other potentially mucosal secretions on them. One area that has gained traction recently, and there has been mounting evidence, is the idea that the virus, SARS-CoV-2 virus, is aerosol transmission plays a part in how one individual may become infected. Recently, there was a letter from 239 scientists across the globe, and this is a little wordy, but I think it's important, and I put this emphasis on the slide. Within a document or in a publication sent to WHO, they say that they demonstrated beyond any reasonable doubt that viruses are released during exhalation, talking, and coughing, and microdroplets small enough to remain aloft in air and pose a risk of exposure at distances beyond 1 to 2 meters from an infected individual. So if you think of 1 to 2 meters, that's approximately an upper end of 6 feet. So they are saying within this paper, within this publication, that there is a chance that there is information out there that says that it can spread beyond that 6 feet. Within also the document, they say the airborne transmission pathway is the only plausible explanation for SARS-CoV-2 super spreader scenarios where crowded conditions were present and where ventilation was inadequate. They have evaluated some of the publications that have been out there and identified that there are no other explanations on how some people got the virus other than airborne transmission. The publication goes on to say that there is more than enough supporting evidence for SARS-CoV-2 airborne transmission despite the lack of universal acceptance for this exposure pathway, and it's important. As I said before, CDC says we're still learning how this virus spreads. The more and more information that is being published out there lends to the idea that there is airborne or aerosolized transmission of the virus because of the number of people becoming infected, depending on whether it's a crowded condition outside or even potentially inside. This is what we are paying attention to in the science, because if we have to understand that, there is potential for aerosolized or airborne transmission, then we need to take precautions against that exposure. As I said previously, the CDC believes that it is mainly transmitted from person to person using respiratory droplets. So let's get into the distinction here a little bit on what aerosols are versus what droplets are. We've probably all heard these terms, and they're used somewhat interchangeably by different people in different professions, but I want to break it down a little more. So transmission of an infectious agent from respiratory secretions is typically classified by public health agencies as either respiratory droplets, which are greater than 5 micrometers in aerodynamic diameter, or droplet nuclei, which are typically less than or equal to 5 micrometers in diameter. So droplet nuclei, which are considered particles, are formed as a result of desiccation when the suspended droplets are desiccated. A process that can occur in less than 1 second for droplets with a small initial diameter. So that means if you are breathing out very small droplets and you're in an exhaled breath, that wet droplet can quickly desiccate into a small particle, a dried particle. and that can be aloft in the air for a certain amount of time. Um, there's an idea that that aerosol transmission is only a healthcare issue, and I have that question mark in here because the World Health Organization says airborne transmission of the virus can occur in healthcare settings where specific medical procedures called aerosol generating procedures generate very small droplets called aerosols. Well, we'll get into this a little bit in the next slide, but it is important to remember that we are kind of all talking about the same thing. We're just using different terminology for it, which we'll get into next. Well, now we're going to get a little discussion on aerosols. And what is an aerosol? Well, if we're looking at the traditional industrial hygiene definition of an aerosol, it's a collection of solid or liquid particles dispersed in the gas, like air. There's a large range of aerosols. They can range from the nanometer scale up to 10,000 micrometers and beyond. So I said before we talked about respiratory droplets, let's talk about respiratory aerosols. Typically, respiratory aerosols are up to a diameter of 100 micrometers. However, there are studies that have been done that show that depending on what activity we're doing, whether it's a sneeze or a breath or a cough, we can generate larger particles. As I said, they can be from different activities. And just to clarify here, there's a terminology out there that is called bioaerosols, and that's just simply an aerosol of biological origin, whether it may be a bacteria, or whether it may be a fungi, or it may be a human. There are still aerosols that we're generating. And here's the main point. Aerosols versus droplets. Regardless of the name that we call it, both droplet types are classified as aerosols under the traditional industrial hygiene definition. So when we hear someone talk about aerosols, we aren't thinking in terms of how an exposure to a respiratory droplet or droplet nuclei may occur, because we know that those are encompassed within aerosols. We're going to get into a little more about aerosols in the next slide. So we've talked a lot about aerosols, so let's understand a little more about the physics of aerosols. So aerosols' physical characteristics are going to influence how long they remain suspended in the air. Now, the size of the aerosol, the shape, and the density of the aerosol are going to be major players in how they travel within an airstream. Larger aerosols will settle more quickly due to gravitational forces and air currents, whereas smaller aerosols will travel further. That's important to remember, and we'll look at that on this next slide with some information just so we get a visual on how it can potentially spread beyond the 6 feet that is currently in the guidelines. This is a very good figure from a research study that the authors made to show how medium and large versus small aerosol transmission will occur. So on the left of this figure, where the gentleman in right is generating aerosols, we can see that there is a trajectory towards an individual, and they're medium and large, and they will fall rather quickly, highlighted by the large blue dots falling near the feet of the first individual. The second talks about short-range airborne route transmitted by aerosols, and even long-range can be transmitted by aerosols as well. So there is a short and a long-range potential for aerosols. And again, as we discussed earlier, within the description here, it talks about small droplets or droplet nuclei, then it says, or aerosols. So we're all talking about, again, the same thing, whether it's a droplet nuclei, a respiratory droplet, or aerosol. It's just, the virus doesn't care what you call it. The main thing is understanding the routes of potential transmission. So now that we have all that information, where do we stand with SARS-CoV-2 and aerosols? Well, being in the moment, in the research moment, we are right now, makes it very difficult. This research is going to be going on for years, and we're going to be able to use this information that we gathered here to guide best practices going forward. One thing that we do not know now is the infectious dose or concentration of SARS-CoV-2 that will result in COVID-19. We just don't know that, which makes understanding some of the infectious routes a little more difficult. We have to presume that things will occur without knowing the concentration. I like to point this out because this response from the WHO is kind of directly targeting that publication by the 239 scientists and other information and other inquiries that they have received. It says WHO acknowledges that there is a possibility of aerosol transmission in non-healthcare settings, because up to right now, other places have said, okay, well, if you're generating aerosols in a healthcare procedure, there's a possibility. But WHO says that there is a possibility outside of those settings. They identified some that says crowded indoor spaces. Well, I don't know what crowded is. I don't know if crowded is 5 people in the 10 by 10 room or 50 people in the 10 by 10 room. Inadequate ventilation. Well, what is inadequate ventilation? They don't quantify. Is inadequate ventilation doing what we have now, or the usual flow rates we have? Or is it something less where we're just kind of in a natural ventilated state? That's important information to find out. But this one is the real important thing that they said. And I'm quoting it here. It says, much more research is needed given the possible implication of such a route of transmission. That's very important to point out. They don't want to make the call unless they have a lot more information, even though we have a lot of anecdotal evidence that's leading us toward that. They are not willing to make that call because of what it is, because there is potential that the guidelines that they've given to now may not be adequate for what needed to be done at the beginning. And I'll point out, this next for CDC and another airborne illness for tuberculosis. We know that we want to stay away from aerosols from tuberculosis or droplet nuclei, but in CDC guidelines, or in a guidance document, it says information on the transmission parameters of M. tuberculosis is also incomplete. Neither the smallest infectious dose of M. tuberculosis nor the highest level of exposure to M. tuberculosis at which transmission will not occur has been defined conclusively. So we're talking about a disease that's been around for a long time. We're trying to apply knowledge that we've had for other diseases for a long time to SARS-CoV-2. They aren't going to want to make the call about SARS-CoV-2 and airborne transmission, yet they still aren't able to put boundaries on tuberculosis. So that's just interesting information. It says, listen, we have a pathogen that's been around for a long time, and we still don't know what the boundaries are on the infectious dose at some levels. So stating that we aren't going to be able to make a determination for the potential airborne transmission of SARS-CoV-2, we may not know that for a long time, if ever. So it may be good to take early precautions now to make sure that employees are not exposed to any aerosols generated from an infected individual. So now we have a better understanding of aerosols and the potential other routes of transmission beyond just what is recognized in the guidelines. Let's look at how we can apply the knowledge that we have, the scientific knowledge that we are gaining in the moment, to the hierarchy of controls and for protection of employees at your facilities. Now, we're going to go here from the least effective, which is PPE, up through the most effective for this purpose is going to be ventilation. We'll get into that next. So previously I said we're going to look at personal protective equipment, PPE, because it is the least effective, and I'll explain that a little more. PPE is typically the last line of defense when we're looking at something. When we're looking at the hierarchy, we want to see if we can eliminate it. We want to see if we can do something to substitute for it. And I'm not talking about COVID-19. What if I was talking about a chemical? If there was a chemical in your process where you needed to substitute it for something else that may be less hazardous, you can do that. What about ventilation? We'll get into that. Installing local exhaust ventilation can be a solution. Administrative controls, determining how long someone should be exposed to it to limit their interaction with it. And PPE. If you can't do any of those other steps, you look at PPE and see what it can do for you. So one characteristic of PPE is that it relies on user compliance. You have to make sure that the individual is trained and appropriately trained to understand how the PPE is supposed to be used and how to keep it clean, how to recognize when it may not be effective anymore. In the area of SARS-CoV-2 or COVID-19, we can look at this from a source control versus protecting the individual. PPE is going to protect the individual because it is personal protective, and it is going to be a source control if used appropriately. I'll get into some examples of that in a bit. Shortages, as we knew, of PPE resulted in novel methods for preventing exposures to aerosols generated from infected individuals. Some other issues with PPE is new or inconsistent disinfectant methods for reusing PPE, if anyone was doing that at their facilities. If you're doing some kind of disinfectant, you have to realize or understand how effective it is. Did it permeate the material to make sure that I'll just use the respirators as a continual example here, that the respirator is free from any contaminants? Is it safe once that disinfectant has passed through it and they adsorb into the material, and is the PPE or respirator now safe for the individual? These are all questions you have to think about when you're looking at reusing PPE for an individual that has been disinfected. And just to go a little more about PPE, I know the big one that everyone looks at for COVID-19 are respirators. Usually everyone hears the term N95. There are P100s out there. There are half face masks and full face masks. But I think we need to continue to understand that there are PPE beyond just a respirator, including eye protection. There is some indication, there's some talk about there, an indication that we could be transmitting the virus from a droplet when contacting the eye. So do you need to install eye protection as well as respiratory protection in your facility? Face shields, that's another option. That's what people are wearing. Gowns or aprons and gloves as well are also personal protective equipment for a facility. And again, I want to go back to respirators. If you have a facility where you're having respirators, you need to make sure that you have your respiratory protection plan in place. That goes back to the training. That goes back to compliance with OSHA regulations for what you need to effectively communicate to individuals under your employment. So, as I mentioned earlier, the previous slide, there was a lack of availability for personal protective equipment. And as I go through some of the slides here, the next few slides, one thing here is about risk communication. So I'm going to factor in some risk communication here for what we want to do and get across when we're talking about personal protective equipment. As I said, there were disinfectant techniques. There are also people who are using novel methods for spreading the virus. They are using novel materials for the masks, and that makes things a little more interesting. There are two clippets from some news stories here that says a nurse in Texas develops a mask with better filtration than N95. And the other story here says that innovative mask blocks 99.9% of particulates, making it about 4% more effective at blocking the particulate material than an N95, according to this one physician who's a professor at this university. It's important to understand that personal protective equipment like that, like a respirator, is engineered and tested to have a particular fit, to work in a certain way. It will fit against your face in a certain way. You have to get the appropriate size. You have to have those respirators fit tested to make sure they fit, make sure they're not leaking, because air will look for the path of least resistance. And if there are air pockets around where the mask is, the air will go around the mask, between the mask and the skin. You can't have a beard when you're wearing one of these. That will impact how it fits on the face. So it's important for effective risk communication to the end user, because both of these stories are conveying incorrect information to the end user. While the material itself that they use may be more effective at filtering, the design of the mask that they had is not. And I'll tell you, the design that I looked at from at least one of these looked like a coffee filter with a rubber band around it. So I can tell you that is not fitting appropriately, because if you give someone some personal protective equipment like a mask or a respirator, you tell them that it is more effective than an N95, then they are going to wear it and think that they are more protective and can potentially be more haphazard in other activities. So just when they are doing the work around someone who's an infected individual, they may have no problem getting very close to them because they figure they don't need to social distance because they have a mask that's 99% effective. It's better than 95. So it's important for effective communication of risk when you're looking at these types of scenarios because you don't want someone to have a false sense of security from a piece of PPE you give them when the person who made it doesn't fully appreciate what is necessary for the testing and the requirements for a respirator. I'll quickly discuss face coverings here. A face covering is what I would consider an administrative control. Face coverings are not personal protective equipment. Face coverings only serve as source control. That means they are controlling aerosols or respiratory droplets or droplet nuclei, or whatever you want to say, from an infected individual. It is not a means of personal protection. So that means that that individual wearing a face covering or face mask is not going to be protected from anyone else. They are protecting others from themselves. What are some examples? Well, there's surgical masks that are out there. There's a variety of cloth masks, and I've seen the studies that they have one-layer masks, two-layer. They're made of cotton. They're made of polypropylene. They may be pleated. They may be not. They are also people who are using bandanas out there or something called a gaiter or a neck covering. What is interesting is there have been studies done for years, 10, 15 years on different kinds of face coverings, and I'm not going to get into the efficacy of these different face coverings other than to say a recent study came out to evaluate individuals who are generating aerosols, and they looked at neck gaiters, and the material that neck gaiters were made of actually created more aerosols or more particulates in the air than just normal breathing or coughing without anything covering their face. So one thing to keep in mind here as an administrative control is that if you have a facility that people are wearing whatever they want in there, if they are wearing their face covering, if their neck gaiters or their bandanas, an administrative control for mitigating exposure may be for you to have a uniform application of either face covering or respiratory protection. You know, if you're going to require everyone to have an N95 mask, if you're going to, or you're going to require everyone to wear a face covering, make sure it's a uniform face covering. Make sure that you are providing them the face covering and they are understanding what it is for and what it is not for. Relating back to the previous slide, this is a risk communication point on face coverings. What to do and what not to do. You would be very surprised at how you see people wearing their face coverings. Like in the individual on the left has their nose exposed. Well, we don't generate aerosols only from our mouth. They come out our nose as well. What about the one in the middle there, where they have it too high on their chin, where they could contact their chin? So what is going to happen here when we move to the third one from the left is that if someone is touching their chin because their mask is too high and then they pull the mask down over their chin, whatever was on their hand is now on their chin. And what was ever on their chin is now on their mask. So when they pull it back over their face or over their mouth, whatever they may have contacted on their hand is now directly in their breathing zone. So it's important for you to not consider not only using uniformity when doing a respiratory protection plan or using respirators or using face coverings, that people understand that there are effective ways of using them and how not to use them. So again, I go back to the risk communication aspect of this is very important. The next highest step in the hierarchy are administrative controls. And we're going to touch on this briefly because I went into more detail on administrative controls in another presentation called Plant Cleanliness and Facility Risk Mitigation from Closure Due to COVID-19. If you'd like more information on administrative controls, that's a good presentation to gain that information. So what are administrative controls? They are actions taken by management to reduce potential indoor exposure, whether again it be to COVID, the SARS-CoV-2 virus causing COVID-19 or any other kind of chemical or biological exposure that you may encounter in the workplace. So what are those kind of administrative controls? Well, there are changes how employees interact with the work environment. That could be assigned work zone. It could be assigned workstations. It could be assigned tools for that individual to use or even shift work. about workplace cleaning. I get into that in detail in the other presentation on why you need to clean, what needs to be cleaned, and how you do a facility evaluation. Another administrative control is, again, social distancing. How do you zone employees when you're social distancing them? And depending on the amount of employees in the space, you may need to have further distancing. And again, if there is aerosol transmission, how does that play into how you manage those employees? So the next more effective control that we look at are engineering controls on the hierarchy. When we're looking at engineering controls, they place a higher level burden at the facility level. It takes the individual out of the compliance equation. That means that we don't have to rely on them to appropriately use face coverings or PPE because the burden is on the facility and the mechanical operations in that facility. You look at reliance on existing systems for control. And you can, if necessary, depending on the scenario, use engineering, administrative, and PPE controls to maximize risk mitigation. You can have a combination of all of those to get a better relative risk reduction than any one control alone. And it's going to depend on the exposure scenario and the agent that we're actually investigating. There are additional costs for building owners and operators sometimes. Some facilities are already designed to have these engineering controls in them and just can be augmented for whatever needs occur. Some of the facilities, whether they may be older facilities or facilities that are not equipped for it, I'll just say an office space or an administrative suite built onto a factory, may not be as easily engineered as the facility may have been. But there are practical control methods that you can look at, and you have to weigh those versus the risk of non-compliance. And we'll get into some of those practical control methods in a bit. So we'll discuss some examples of engineering controls and get into them in a little detail. The first example is a very simple engineering control. It can be a physical barrier. It places a plastic guard or any kind of other guard between individuals. What about automation of interactive processes? There can be sensors on automatic doors. How about ventilation, as we said, local exhaust ventilation or dilution ventilation, depending on the setting, and even filtration, or inactivation devices like ultraviolet, germicidal, irradiation, or UVGI. The first one here we can discuss is a physical barrier. It can separate individuals during a task. You see here, this is a CDC sourced figure. It places a barrier like a partition to keep workers from each other. This may be good in theory. It may work in some scenarios. However, I have seen scenarios where they have different sizes and different levels of plastic separating people that have holes in them so you could hopefully hear what they're saying. But the people behind those barriers have masks on, and if you can't understand what they're saying, they get up close to the hole, they pull their mask down and speak through the hole. So if they are doing that, is that physical barrier still an effective barrier at keeping people's, I'll just say, personal zones separated? Because as soon as you compromise what you're doing to protect yourself, getting up close and pull your mask down, that barrier is no longer going to be effective for what it is designed for, if it is providing any protection at all. Because again, there's different sizes. Some stores I have been in have very small plastic sheets as sneeze guards in front of the cashier or wherever you go. Other places in front of reception have these huge plastic sheets that go almost all the way to the ceiling, as I say, and we'll get into this here in a minute because there are some ventilation areas that are behind there that could be pulling air from the one side of the barrier to the other. So you have to take the physical environment in consideration when you're establishing these physical barriers. Well, what about automatic sensors on facilities? Well, as I discussed in the other presentation on plant cleanliness, you want to look at areas that are high touch. If there's a door handle or a doorknob or somewhere that people are touching often, you may want to clean that more often. You know, one way to eliminate the need to have that contact is with automatic sensors on doors. They can reduce high contact points, as I said. What about if you're in a bathroom and you have an automatic sink? Instead of having handles, you can have an automatic sink. However, there are issues with automatic sinks as well. As I discussed a little bit in plant cleanliness issue, the presentation, I also do Legionella investigations of facilities and impacts of those, and those can be problematic. The solenoids and automatic sinks have been shown to harbor Legionella bacteria on those. So you have to weigh one engineer controlled against another, one hazard against another. Are you taking care of one potential transmission route for SARS-CoV-2 by installing automatic faucets on sinks, but potentially introducing another hazard like Legionella into your facility by doing that? These are just things you have to consider if you're wanting to make changes. What downstream effect are your engineering controls potentially going to have on employees at your facility? And you'll also have to look at implementation of those. Can that be done quickly? Or there's a lag time on that? It's costly as well in certain scenarios, especially if you're talking large projects or large operations. All that has to be considered when you're looking at potentially using automatic sensors as engineering controls. So the one I'm going to spend a little more time on here is ventilation. So if we are looking at something that could potentially be aerosolized, ventilation may be a practical way of reducing exposure to that aerosol. It can be effective. The American Society of Heating, Refrigeration, and Air Conditioning, ASHRAE, put out a position paper in April in 2020. Within that document, it says, the following HVAC strategies have the potential to reduce the risk of infectious aerosol dissemination. So looking at distribution patterns, room pressurization, personalized ventilation, capture ventilation, filtration, controlling temperature, and relative humidity. So ASHRAE has acknowledged that using HVAC strategies or HVAC systems have the potential to reduce the risk of infectious aerosol dissemination. And we're going to detail that a little more in what we're discussing today, especially if the aerosol transmission route is a potential way that people become infected. So depending on your operation, you may be familiar with this first one for the use of local exhaust ventilation. Here's a picture of an individual that's doing some welding on what looks like a pipe using some LEV, and it focuses on an individual's task to control source exposure. There may be a limited application of this methodology due to the design of the system and reorientation of personnel. Is it possible to use a local exhaust ventilation to mitigate exposure from this? It may be difficult. Again, the design of the system, the capture velocity of these systems may not be up to snuff for what's needed for an aerosol. And if you're having to require one individual to stay close to this local exhaust ventilation, it may not be feasible for an entire work shift. The other type of ventilation, which is probably a little more practical, is the use of dilution ventilation. That's using quote-unquote clean air to dilute the indoor environment. Lowering the exposure through dilution of indoor contaminants. You're going to be using outdoor air if you have a facility that is a shell facility that is indoors but not conditioned. You may have vent fans that are blowing outdoor air into the facility for a dilution effect. You may have makeup air where you're bringing in air from another area to kind of dilute the air in that one particular work zone. You can look at increased air exchanges in an occupied space. If you have a set volume of air moving through a HVAC system in an office space, and you want to increase that, that may be a viable option. And use of filtration. There are different filters that you can use to increase the capture of any particulates that may be in the air. So I want to talk about outdoor air for a moment. There are some indications, some guidance, and some others that increasing outdoor air introduced into a space that you should do that, and some suggest 100% use of outdoor air in your space instead of doing any recirculation. They say that you can open windows in a space, you can use outdoor air dampers on HVAC systems and open those to the fullest and get as much outdoor air within your systems as possible. However, there are potential drawbacks of that. So again, everything that we discuss here, whether it's ventilation or administrative or personal protective equipment, you're going to have to, it's going to be very context specific to your one specific facility that you're concerned about or the one specific location. So for example, if you have an area that has a high humidity and you have an office space and you're using 100% outdoor air, let's just say, You may be dealing with issues of high moisture content in the indoor environment. You could be introducing moisture into building materials, and that could lead to the potential growth of mold on those materials. So that's one thing you have to keep in mind. If you're using opening outdoor dampers or outdoor air dampers on HVAC systems, and again, in high humidity environments, you may be overworking the system. The system may not be able to fully remove the amount of humidity that you're introducing to it, and it could be both overworking it and underserving the conditioned space. And another thing to consider is the quality of the outdoor air. You have to take that into consideration. I'll use a simple example of if you have a facility and you have someone's doing construction next door and there's a lot of particulates from dust or dirt and debris in the air, you could be introducing that into your indoor environment. But what about other areas? What about, well, let's say the West Coast, California, Oregon area right now, where there are fires everywhere. There's a lot of ash and other air contaminants around. It is not feasible to use outdoor air for dilution just based on what's available. So that always has to be kept in mind is you can do these solutions, but what could you be introducing? What other hazards could you be introducing if you're going to look at using 100% outdoor air in your facility? So along the lines of ventilation, you can use enhanced filtrations and HVAC systems, including a higher rated filter in your system may capture more particulates. You can look at using HEPA filters. They capture 99.7% of airborne particles, zero point 0.3 microns in size. You could look at using higher filters with MERV, minimum efficiency rating value, of MERV for 13. Filters, but you have to understand that if you're going to put something that's going to occlude airflow in a system, then you may have to increase the airflow in that system. And sometimes those system limitations may prevent the effectiveness of those. So we'll get into this a little more in the next few slides, but that may be one thing you can do in a facility or an area or a workspace to increase the effectiveness of the ventilation. But again, that risk has to be communicated. What is the risk of using these enhanced filtrations? Well, you could be overextending your HVAC system if it's not designed for it. Or it may not be capturing what it's supposed to do. It may not be cooling the way it should be or conditioning the indoor environment. So those are things you have to keep in mind when you're trading one potential control and for another. As I mentioned on the previous slide, you can use filtration as one way to ensure that the aerosols or particulates in the environment are reduced. Another is increasing room air exchanges to reduce exposure. This method is typically used in healthcare settings and scenarios. They have a certain amount of minimum air exchanges per hour, ACH, that is required to make sure that people in that space are not exposed or it's capturing anything generated by an infected individual, whether it be for COVID-19 or any other disease or virus that may be transmitted. These are minimum established capture velocities or air exchanges from the CDC. So if you don't have an HVAC system that has the ability to be cranked up that high, or you have a large airspace or a large area that just the HVAC system is just not going to fit, or you may not be able to feasibly do it, you can look at using portable HEPA filtering devices to aid in achieving those additional air exchanges per hour. Some of you may have seen these devices. They're called air scrubbers or negative air machines, and they move a lot of air through them. That's what they're designed to do. Based on numbers for healthcare settings, the target, at least if you want to reduce exposure, is at least 6 air exchanges to have an impact on an occupied space. Now, you may need more units depending on the size of the space or the condition or the layout of the space. So that's one thing that you have to consider. As I said before, you have to consider the physical environment when you're establishing these engineering controls. So this is an example that we have come up with. This is from an AIHA guidance document that we put out on reducing risk of COVID-19 using engineering controls. And I'll show a link to that at the end of this presentation. It gives the example of using 1,000 cubic foot room, and if you are just using, we'll just use the example for using your HVAC system, and you're only getting 1 air exchange per hour. So in this example, it uses outside air to dilute to show that it can increase the potential air exchanges per hour by 1. If you are using 5 HEPA filtering air scrubbing devices, you could be getting that 6 air exchanges per hour. That's 6 times the volume of the room clean, quote unquote, clean each hour. That's a turnover, that's a filtration, that's recirculation of that air clean through these HEPA filters. And that's something interesting to keep in mind if that is feasible for the setting that you're in, to use these. Again, you can replace the box that says outside air with filtration. You may be able to do that with additional filtration in your existing HVAC system and supplement it with additional HEPA filtering devices. One thing to keep in mind if you are using these HEPA filtering devices in any space, and again, you want to make sure that you're not replacing one hazard for another. These devices need to be cleaned on the schedule. Anyone who's doing that cleaning needs to take the appropriate precautions. So if these devices are intended to capture aerosols, they are going to have those aerosols concentrated on the filter within them. So again, effective risk communication to the person responsible, whether it's an internal person or an external third-party vendor who comes in and cleans these. They need to understand the risks. They understand that they need to use personal protective equipment when cleaning these. They need to be cleaned with disinfectant. They need to have a cleaning protocol for these HEPA filtering devices because, again, you don't want someone who's cleaning them to be exposed to a concentrated form of any aerosol that may be gathered on the filter itself. This is a figure included in the AIHA guidance document to visualize the relative risk reduction. So when you're using an N95 respirator that's down there in the red, if you look over the relative risk reduction, it's 90%. So when you're using an N95, N95s have an assigned protection factor of 10. So that means they're going to reduce any exposure that you may be encountering. Most exposures that the respirator is designed for, it's going to reduce those 90%. So an N95 is going to give you a 90% relative risk reduction. If you are looking at using face coverings, and here it goes through all occupants or only COVID positive, you're looking between 5 and 10% relative risk reduction. And that's based on a variety of masks, non-compliance, half compliance with people, or inappropriate materials. We're accounting for a number of different things when we're looking at relative risk reduction, just based on face masks, not standardized like you may want to do for your facility, but anyone who's coming in with face masks from anywhere, especially if they're positive. So up above, it says there are effective engineering controls in the yellow. So it looks at the relative risk reduction. So if you are not able to get at least 6 air exchanges per hour to be at that level, which is going to give 95% risk reduction, you may want to consider saying, listen, it may be best for me in this scenario to use N95s because those are going to give you a 90% reduction. If you can't get up to 6 air exchanges, which is greater than the 95%, then it may not be feasible for you to use those engineering controls. So my recommendation here, if you're on the fence or if you're considering engineering controls, is to consult a professional, consult someone who does this for a living, who can evaluate risk and say, you know what, it may be better for your employees to use, or your facility to use this type of control instead of this one, because it may not be as effective as you're intending it to be. So always keep that in mind, is that when you're looking at this, looking at relative risk reduction, you have to consider how effective the controls are and what your intended purpose is. The last control method we'll look at is ultraviolet germicidal radiation, UVGI. These have been used in healthcare settings, and they are also used in other particular settings. They may result in reduction of airborne infectious agents via deactivation. The problem with potentially using some of these is the installation and use may require modification. What is the effectiveness of these methods versus other methods, and what is the exposure going to be from UV radiation to your employees? If you have a large area and do you need one of these or do you need 15 of these? And if you have 15 of these, what is the exposure that the people that may be around is going to incur? So that's just something to keep in mind. Again, are you mitigating one hazard and replacing it with another that you aren't understanding or not aware of what the potential impact of your employees may be? So that's just something to keep in mind, and we'll cover that a little more in the next slide. So I covered this a little bit in the plant cleanliness and facility risk mitigation presentation, but it's important to note here that these technology controls are also going to be considered could be considered engineering controls. And there are technologies that people are selling for installation in different places and different facilities to either clean the air by introducing some kind of ions or ozone or something, or using cleaning methodologies with novel application techniques. So let's cover the first one. There are a number of different devices that may be installed in the HVAC system that are called plasma air cleaners. It could be ion air cleaners or something like that. These, depending on the product, they may be introducing harmful byproducts into the workspace. I know that some of them have some data available on what they do. So I've seen some safety information from the manufacturer that I question how they came to that information because it's not clear. So if you're introducing any type of product, whether it's a plasma, whether it's this vaporized hydrogen peroxide system, which requires very specific use condition because it introduces a vaporized form of hydrogen peroxide into the air, or if you're using ozone generators to clean the air, you need to have a safety and health professional evaluate what you're thinking about using. For example, if you're introducing ozone, it's an irritant. You could be causing people to cough or have lung problems if you're using that to clean the air and people are still around, even if there needs to be a clear out time, a dilution time for that if you're using it. For vaporized hydrogen peroxide, again, you could be introducing an irritant. It has very specific limits to reentry. So if you're using this in a non-airtight setting and you're letting people go right back in, what hazards are you introducing them to in that workspace? Fogging is another thing. So there are some people when they're doing facility cleaning, as I mentioned as an administrative control, they are applying disinfectants via a fogging application. And unless the EPA, who evaluates disinfectants, has looked at the safety of fogging and the efficacy of it, and then if they have not done that, then it is not recommended that material be fogged. There are very specific use conditions included on labels of EPA-approved disinfectants that you need to consider. So when you're looking at using any type of technology as a control, whether it's an engineering or administrative, you have to understand that you could potentially be potentially eliminating one hazard, but introducing another into the workplace, and what effect and impact is that going to have on the employees that may be exposed. These are some AIHA COVID-19 resources that are available to anyone who wants to download them. We discuss personal protective equipment for SARS-CoV-2, discussing recovery from COVID-19 building closures, which I covered in the cleaning presentation, proper use of respirators for healthcare workers, and I'll say first responders, because if you have anyone who's a first responder qualified or you have that need at your facility, it may be a good resource. And reducing the risk of COVID-19 using engineering controls, which is the ventilation that we had discussed. A good resource for these and other documents is backtoworksafely.org. On there we have industry-specific guidance for businesses to safely reopen and re-engage. So if you want to find any of these, you can easily go to backtoworksafely.org and download them. Thank you everyone for attending. I appreciate it. If you have any questions or need any additional guidance or anything else based on any information that I presented in this presentation, I'm happy to discuss it with you. Please feel free to reach out. My email address is on the screen. My phone number 321-263-1333, and my website www.exp-assessment.com. And again, I'll be happy to answer any questions that you may have on follow-up on this presentation.